acknowledgement. We acknowledge that the University of Alberta is located on Treaty 6 territory, respects the histories, language, and culture of First Nation, Métis, Inuit, and all First Peoples of Canada, whose presence continues to enrich our vibrant community. And my personal addition to that is to say that, I think in transplantation, we all respect that we have a commitment to serve all patients in the best possible way from a transplantation perspective as well. And so welcome everyone to the 2025-2026 ATR Seminar Series season. We'll be hosting many local, national, and international speakers, like our speaker today. And we welcome any suggestions for topics or speakers. And you can email us at transplant@alberta.ca, and we can put that in the chat too, or you can respond through the ATI email messages as well. So we can get started for what's bound to be an excellent talk today. I'll introduce our speaker and then I'll let him take over with his presentation. This is a hard person to introduce because there's so many things to say about Dr. Stan Jordan, but I'll try to hit the highlights here. His professional life continues to be dedicated to improving transplantation rates for highly sensitized patients through human leukocyte antigen, or HLA, as well as ABO blood group incompatible transplants. And he's definitely a pioneer in that space. Dr. Jordan's team developed the first desensitization protocol to reduce anti-HLA antibodies in the early 90s, and this work resulted in the use of IVIG as a desensitization agent by Medicare in the US, and he's published more than 400 peer-reviewed manuscripts and 14 patent applications in work related to this space. He's done important work in IgG endopeptidase prevention of antibody-mediated rejection, published in the New England Journal. Many other uses of this drug, now known as imlifidase, has allowed for approval of desensitization protocol starting in 2020. His team has also published evidence with anti-IL-6 receptor therapies, and there's just looking at all these awards that he's won. So, he's won the Cedars-Sinai Prize for Research in Scientific Medicine, the PRISM Award, as well as awards for outstanding achievement in transplantation from the Transplantation Society, from the International Society of Nephrology, Senior Achievement Awards in Clinical Transplant from the American Society of Transplantation, and on and on. So most recently, very probably meaningful reward, I'm sure, to Dr. Jordan, as he received the Medawar Prize from the Transplantation Society. So without any further ado, I will let him get cracking on his presentation, Evolving Therapeutic Considerations for the Management of Allosensitized Transplant Patients. Thank you.
Hopefully a lot of ground regarding the advancements in desensitization and treatment of antibody rejection. Let's see if I can go forward here. I start with this picture because it was many years ago when I was in India making rounds with this patient. The doctors there presented him to me as a man who had rising creatinine proteinuria and a biopsy that was diagnosed with chronic allograft nephropathy, which really doesn't mean anything, but we know now this was antibody-mediated rejection. At the time, we really didn't have ways of diagnosing it, and no treatments really, potentially using thymoglobulin, and we were just starting to use IVIG. So made a lot of progress since then. So I want to go over that. Again, we know that antibody rejection is a big problem. I won't spend much time on this. We know that it accounts for about 50% of graft losses long-term. It's been poorly understood until recently with the development of DSA monitoring, or the use of Luminex beads to detect HLA antibodies, and then the pathology from the beautiful BAMF system, which has really advanced our understanding of this process. And many years ago, we looked at our place, we had 80 patients that we looked at with antibody rejection, and Mark Haas did a very nice job with this. And panel A, you can see that he described it as ABMR that's pre-existing type 1. We now know this is acute AMR, where you have antibodies at the time of transplant. We get glomerulitis and some inflammation. And then type 2, which we would call now chronic active antibody-mediated rejection. You can see that maybe counterintuitive that type 2 has much poorer graft survival over time. And in this case, you can see very significantly different. And when we looked at a very important category here of assessments is looking at the patient's response to reductions in antibody therapy. And certainly at that time, we had mostly IVIG and rituximab and pheresis. You can see with the change in what we call our relative intensity score, if we couldn't change the score very much, you can see that patients did not do well. But antibody reduction was associated with improved survival over time when it was accomplished. So let's start by talking about trying to understand the immune activation pathways that are responsible for antibody rejections, and then we'll get into clinical insights for new drug developments. There's a couple of papers here I'd like to recommend if you want to look at them, and there's some others that we'll talk about later, but I think last year, we published this paper in Nature Reviews looking at translating B-cell immunology to treatment of antibody-mediated allograft rejection, which will cover a lot of what we'll talk about today. And then I want to also talk about this article briefly. Late B-cell action is dysfunctional tissue repair following kidney injury and transplantation by Pietro Sippa. And one of my colleagues, one of our division of nephrology members, Dr. Kumar, who has worked looking at ischemic injury and its nexus to immune activation. And we'll talk about that paper first, because what was so interesting here is that with Pietro, he had protocol biopsies that he did on patients. You can see down here on B, C, and D below that the protocol biopsies were performed at baseline, 3 months, and 12 months. Here he looked at patients who had ischemic injury to their kidneys, and you can see what he found when they did bulk mRNA analysis of these biopsies, that there was strong development of a B cell and immunoglobulin gene activation, as well as plasma cell development over the 12 months of observation. And if you look at here at the impact on GFR, that 3 months and 12 months, very significant declines in eGFR over time in those that had ischemic injury. Importantly, up at the top, and I won't dwell on this, just looking at normal kidneys with ischemic injury in mice, you do see the same thing, that there is over time after injury, a development of immune reactivity or infiltration into these native kidneys with ischemia is also associated with declining GFR, suggesting that immune activation may be leading to antibody-mediated entry to the kidneys, as shown in this graph below. Can be both the donor-specific antibodies and also autoantibodies that could do this. So terminating this in some way would be important to cut off this dysfunctional injury with repetitive immune activation that results in graft decline. And one of the important things in this figure I wanted to show you is, and we'll have a paper coming out soon in American Journal of Transplantation, looking at over on the left side how injury occurs, and relating to the previous paper, Dr. Nick Chun at Mount Sinai, whom we worked with one of our complement inhibitor studies, has shown that with immune activation after an ischemic injury, that there is a release of exosomes and extracellular vesicles that contain HLA molecules, and also that are coated with complement. And these bind to a receptor in dendritic cells called our CD11 and CD18, or complement receptor 4, induce immune activation and also alloantibody direct responses. So we think this is how injury is occurring, you get a sort of a shower of alloantigens into the body and even to distant sites that would give a broad activation event. And this results in activation of germinal centers with T follicular cells, activating B cells, IL-6 production is really critical here in driving this process. And then eventually you get plasma cell development with pathogenic IgGs that where we can have ADCC injury. And we also know that IL-6 is, when antibody is binding to the endothelial cells, is generated in the endothelial cells and can cause proliferative obliterative vasculopathy and ABMR. The other important thing to think about here is how the cells are injured. And we know there's two components here of the innate system, that is complement activation. We'll talk about that. And ADCC, antibody-dependent cellular cytotoxicity, where NK cells and monocytes recognize IgG-bound to HLA molecules and then can release cytokines and perforins, enzymes to cause injury. And when we look at the antigenic anatomy of B cell development, there's implications here for therapeutic approaches to human disease. And again, I think this is, I'm sure you're all aware of this, but looking at common monoclonals we have, like CD20, you can see that there's a fairly limited span here going from pre-B cells up to plasmablasts, but even for Rituxan, not so much on plasmablasts. CD19 has a span all the way across to plasma cells, where it will in fact impact about 50% of plasma cells. CD38 or daratumumab and others covers the plasma cells, plasmablasts, and BCMA will cover B cells and the plasma cells as well. So these are BCMA's B cell maturation antigen or receptor for BAFF and APRIL on the plasma cells. So we'll get into that as we go through the talk today. And so there's types of therapies we would be looking at now with this type of identification immune activation process would be anti-cytokine therapies that could block the IL-6 pathway, or anti-BAFF, anti-plasma cell therapies, anti-CD20 still important, interfering with the germinal center with CTLA-4 Ig, anti-CD28, and then drugs that would affect the NK cell, ADCC pathway, and of course, drugs that would just reduce antibody, high affinity IgG antibodies to HLA class 1 and 2 will be important. Well, let's look at the a dawn of the new therapeutics and get right into this. And first drug you mentioned is something we've worked with from the very beginning, starting in 2015, imlifidase, which cleaves IgG molecules in half. You have three stages. First, before the enzyme is administered, then single cleaved within a short period of time, and then fully cleaved into FAB prime 2 and FC. Obviously, the bacteria has figured out that ADCC and CDC is that if you get rid of the FC fragment, you'll get rid of those important pathogenic pathways for elimination. So borrowing from these streptococcal pyogenes, we can see that if we, again, can completely cleave, we get rid of CDC and ADCC. Single cleave probably gets rid of complement activation and plus or minus ADCC. And the original study, and I won't spend too much time on this, it's been published several years ago. You can see that the aha moment is above, that with the Luminex, this patient very highly sensitized. This is the first patient was treated with imlifidase in pre and post. You can see that very rapidly after 6 hours, all the IgG antibodies are gone. There's a little bit at the bottom here. That is, we subsequently found this is single cleaved. But more importantly, if you look at C1q or complement activating antibodies, they're gone within an hour. I think this has a lot of implications for treatment or getting rid of antibodies in patients that are heart transplant or lung transplant, where we can create an antibody-free zone very quickly to transplant these patients. But antibody rebound obviously remains an issue here, and that has been a main problem with this. But overall, I'll go through some of the other studies we've done. One of the things that with rebound, we first noted, and over here on the The first study was, there's a group in Sweden where they didn't do any pre-desensitization and did not give Retux or IVIG afterwards. You can see that rebound occurred quite quickly within 1 month with antibody rejection. For us, we didn't see that because you can see very little at 1 month, but up to 3 months, we did see some because we used desensitization up front, and also we used IVIG and Rituxan afterwards to blunt this memory B cell response. And we think that is really translated into the prescribed protocol for both EMA and hopefully FDA approval for this drug for desensitization. Now, again, we did several studies. This was a follow-up study to it where we looked at a large number of patients, and using this protocol, we had good outcomes there. 89% transplanted, 100% graft survival at 6 months, or the patient survival, and about 88% 6 months. Subsequent studies in a phase 2 trial, the HIDUS, very similar reports. We had, I think this study was important, especially the upper panel. This was a 3-year outcome. And you can see look at the data for the 99.9% CPRA patients. And here's the patient survival and graft survival. I don't think we've seen anything quite like this for this group of patients who would have remained on dialysis and without the benefit of ever having a transplant. The most recent publication here is 5-year outcomes for this group. And we had about 39 patients that were analyzed. I'll go through this quickly because it was just recently published. It was 4 single-arm studies that we analyzed. Graft survival at 5 years, you can see, is at 80%. 82%, excuse me. And the patient survival was at 90%. You can see here also that the eGFR at 3 years was 54, it's 50 at 5 years. Still many patients maintaining really good outcomes. You can see the trajectory of the antibody here. These are the immunodominant DSAs. Over the 5 years, there's a tendency to go down to non-pathogenic levels for both class 1 and class 2. And this is the overall summary here, that we had 90% patient survival, 82% graft survival, and 50 milliliters per minute per meter squared GFR, again, for these mostly 99% patients. So we think there is continued optimism for this. We have finished now the ConfIdeS study for labeling. It will be evaluated soon and submitted to FDA, hopefully for FDA approval of this drug. It will be a very welcome addition to our armamentarium. Just a brief word, we did look at treating patients with comparing IVIG and Plex to imlifidase and then rituximab. So IVIG, Plex after pheresis, IVIG, rituximab, the groups for Plex and then IVIG rituximab versus imlifidase, IVIG and rituximab around 5 days. What we found here was most importantly is that I think this is important information, is if you look at the median reduction in DSA was 97% for imlifidase compared to 42% for Plex. So Plex is not very, very effective in getting rid of these antibodies. And so I think that we did not see very good outcomes or any difference in outcomes, I should say, because I think we're still dealing with the rebound, and there's a lot of work that needs to be done there in terms of looking at other therapeutic options. And we know IL-6 blockade and also the anti-CD38s may have better potential here. But I think getting rid of the antibody, this is an important therapeutic agent, could be useful in early antibody rejections. And so I think any trials that we do, we have to have good patient selection to move forward with this. Let's talk about interleukin-6. And again, this is something we have a lot of experience with. This is a pathogenic cytokine we showed earlier. It's very important in driving plasma cells and T effector cell functions. Patients on chronic dialysis are sensitized. We reported several years ago have higher IL-6 levels and high CRPs. And in fact, there is now a study with clazakizumab treating patients on dialysis for reductions in cardiovascular disease mortality related to IL-6 expression. This is an interesting paper, I think, and I want to show this because this study has also been completed. This is a work from Jordan Pover several years ago showing that in a humanized mouse model of coronary artery vasculopathy, so human coronary arteries transplanted to a SCID mouse and then reinstantiated with an alloreactive immune system, you can see in panel A that after a month or so, you get this classic coronary artery vasculopathy. And what they noticed as we look in figure B at the top here, that the endothelial cells of these grafts are making a lot of IL-6. Now that's interesting, isn't it? So they're being probably antibodies or immune reactants are activating them to make IL-6. And if they use anti-IL-6, you can see that they reduce the expression of IL-6 in the vasculature, and this also reduced the coronary artery vasculopathy. So very, very interesting. And this has led to a trial of tocilizumab for prevention of coronary artery vasculitis. This study is now complete. About 250 heart transplant patients in the U.S., different centers, randomized to receive tocilizumab for 6 months or placebo. And we'll see if this has some impact on coronary artery vasculopathy and certainly allosensitization events. So it's a very exciting study, and we'll look forward for those results. We started looking at this years ago for antibody rejection. We had, looking at non-randomized study, but tocilizumab for treatment of antibody rejection. We had 36 tocilizumab patients, 39, and time from years. You can see that over years that they were treated, there's a big difference in graft survival. More importantly, I think there's big differences in patient survival that were significant, suggesting that when people's organs fail from antibody rejection and return to dialysis, they have a much higher mortality. So this drug can be very useful in treating antibody rejection. We thought, and we still think so. Desensitization, it works. This is a clazakizumab, and we've not seen anything work quite this well from our own experience looking at patients where the protocol here was plasma exchange ×5 with IVIG, and then monthly sub-Q clazakizumab up for 6 months, and then the study was over at 9 months. You can see that for 20 patients entered, looking at the class 1 and class 2% reductions, that if you look on the left side, that's the percent reductions mean for every antibody the patients had. If it was on the right side, they got worse. So most patients had a response to this by reducing their antibody. We transplanted all 20 of them. And one of the things that we saw that was important, and one of the things we did, I think, was important, is that we continued claza after transplant. You can see here, we do not see this rebound in panel A. Actually, we see a reduction in the pre-desensitization and at transplant DSAs over time, and at 1 year, only one patient had an MFI at 5,000. And they had milder rejection episodes, and more importantly, we saw that the drug increases regulatory T cells as well as B cells in the peripheral blood starting around 6 to 12 months post-transplant, which may have important immune modulatory effects. So we think this is a very important idea in terms of potentially using these drugs post-transplant and desensitization patients to prevent rebound and possibly inducing regulatory T cells and B cells to prevent rejection. I'm going to skip this one. This is a study for antibody rejection, but I think you all know this. This is the claza trial for that Bomig did, showing that claza reduced markers of antibody rejection and DSA levels in patients who were highly sensitized and had antibody rejection. And if you look at the GFR, big differences there in GFR stability over 52 weeks. This studies we did and that he did led to a phase 3 study, but that study, we'll talk about it in a moment, failed. And we'll talk a little bit about that when we get there. So this looks good. I want to get now more to some emerging data that's coming up from I think from tocilizumab, which we were initially interested in. And this is a study that was just published from Noble and his colleagues. You can see here that they looked at patients from 2018-22 with chronic active antibody rejection, or actually let me back up a minute. This is microvascular inflammation, and there's two categories, one with DSAs and C4D positivity, one with negative DSAs and C4D negative phenotype, but MVI. And you can see here that treatment of tocilizumab, well, what they did is they looked at patients from minus 12 months to time 0. eGFR was declining in both groups, and then treated them with tocilizumab for 12 months. You can see here that there's a dramatic decrease in eGFR decline after tocilizumab treatment, and also in glomerulopathy scores in both groups. And I think this is important because the use of tocilizumab here, in studies to date have been used only in patients with MVI, with classic chronic active antibody rejection, with DSA positive, C4D positive. So now we know, and actually Lupi's paper, which I don't have here, was New England recently, that these two categories really look pretty similar in the way they progress. And this was shown in the study. And we actually did the same study, and this has been accepted in Transplant Direct, but we had more patients. They had 64, we had 85 patients, DSA positive and negative. And we see basically the same thing, that eGFR slope went from minus 0.7 cc's per minute, or 8.4 cc's per year in the before treatment, and then after treatment was 0.07 cc's per month. So this means that there was a tenfold reduction in the eGFR decline with this therapy. So we think this is a very important therapy. Of course, the treatment of CLASA did not work. They stopped the study. I think this really put a dent in people's enthusiasm for this drug, which I don't think is justified. The problem is, I think, when the study was had very restrictive entry criteria, but more importantly, they reduced the dose of the phase 2 study from 25 milligrams sub-Q to 12.5. So I think it was underdosed, and possibly that was why we did not see a benefit that was seen in the phase 2 studies. Okay, so IL-6 has a lot of potential therapeutic action, so we think it's could be very useful in chronic antibody rejection. I think you look over on the right side, reducing IL-6 expression in the endothelium could be helpful in both cardiac and kidney transplant rejection. And so it's modifying, even though it doesn't reduce antibody there, then it modifies the impact of antibody. Also over on the left here, we know that IL-6 blockade can flip the narrative in the germinal center from T effector cells to T regulatory cells. And this may be helpful in suppressing further T cell activation and antibody and inducing antibody reduction. So let's talk a little bit more about another aspect of treatment of antibody rejection and potential for desensitization, and this is regulating the half-life of IgG. And this is an important thing. Now, for many years, and I've been, a fan of IVIG forever, and it's gained use and is really still a major component of our desensitization and treatment of antibody rejection protocols. And back when this paper was written in 2006, you can see there was about 900 things we thought were the way it worked. It absorbs complement, it anti-idiotypic antibodies, inhibits B cells and that sort of thing, and inhibits Fc gamma receptor signaling. So much of that is true, but I think we really missed one of the most important critical pathways of how this drug worked. And I wanted to show you this briefly because it's a paper we did about 5 years ago with the Novartis Institute for Biomedical Research in Basel, looking at one of their monoclonals called tezepelumab, which is an anti-C5. And what we did here is we had a group of patients that were undergoing desensitization with IVIG, and they get it on dialysis. We give them a very large 2 gram per kilogram, a max 140 gram dose of IVIG. And so what we did here, we gave them tezepelumab plus IVIG, the blue line, or just tezepelumab by itself, and we looked at PK and PD. And I think just going down to panel B and C is very important here. If you look at the ability of this tezepelumab to suppress Weiss labs or complement activation, you see out even to 30 days and even 58 days, which was the end of the study, it was still pretty effective. But if it's given with IVIG, you can see it by day 15, it loses effectiveness. And the same is true for CH50. Why is that? Well, it's because IVIG can saturate a system called the Fc neonatal receptor system. And this is something that was not known until recently. And this probably explains a lot of the beneficial effects of IVIG on antibody-mediated diseases such as Guillain-Barré syndrome and other neurologic diseases and autoimmune cytopathies where it is used frequently. So what is this about? This is, it's such an interesting story. Just a brief review of this. This is the gentleman, F.W.R. Bramble, who was a Welsh zoologist who wrote this paper back in, I think, 1955. The route by which passive immunity is transmitted from mother to fetus in the rat. And basically what he found out, even though what they knew is that if you look at neonates are born with humoral immunity. How can they develop that? They're not getting any immune stimulation, they're not getting vaccinations, all this stuff. So there had to be some way the IgG was being transmitted from mother to fetus. And basically he found out that in this work that he could cleave the Fc fragments. He gave rabbit antibody to mice, and you could see that, or to rats, and you could see that if you cut off the Fc fragment, it didn't go across. If you had the Fc, it was transmitted. So there was some process that involved the Fc fragments, but he never was able to find that out. Eventually, right in the 1980s, the gene was cloned for what is called the Fc neonatal receptor. And the Fc neonatal receptor, if you look here, is initially felt to be responsible for maternal transport of maternal IgG to the fetus through the syncytia trophoblast of the placenta. So it is a pH dependent for all your nephrologists out there. We know that when the IgG from mom is pinocytosed into these cells, we go from a pH 7.4 to pH 6.5. The FcRn is activated and transports the IgG to the mom. And the same is true for neonatal gut lumen. It's highly expressed at the time of birth. So babies can absorb maternal IgG into their circulation as well. But now we know that this is present in all the cells of our body, especially endothelium and macrophages, monocytes, where IgG is picked up and is transported and recycled. And I'll show you a better picture of that in a moment. It looks something like this. So on the endothelial cell, your IgG is pinocytosed here and goes into these low pH systems where it binds to the FcRn, and then it's recycled. If you block this, like with, and this is one of the drugs we'll talk about, efgartigimod, which has high affinity for the FcRn, other IgGs cannot are not going to be recycled, but they will be destroyed in the lysosomes. And so there is a preferential recycling here of antibodies that have high affinity for the FcRn. So this is a drug that we'll talk about in a moment. So again, they're monoclonals. There are all kinds of other fragments of of antibodies, FC fragments that can block the FcRn system and result in decline. You can see here total IgG goes down very quickly in patients receiving these agents. And these agents are now coming to, as you can see here, into treatment of antibody rejection. So this is a study that has started already, and where people that have antibody rejection, chronic active, that have DSA positivity, are going to be randomized to receive the drug or placebo, and there'll be a crossover group as well. So it'll be fun to see how this works in terms of allowing the degradation of the pathogenic antibodies and then recycling the FcRn, the efgartigimod, to block this system. The main thing, looking at this, we felt that IVIG, again, with all the things we talked about, could be helpful in blocking the pathogenic antibody responses to and reducing antibodies and help modify this. Now you can see here that Dolly Tyan used this figure where at that time we only had cytotoxicity. We could show that adding IVIG to 100%, 80 to 100% CPRA patients is that we would have a reduction in cytotoxicity. And we felt this was anti-idiotypic antibodies, blocking antibodies. And I think that is a possibility. And so it is shown here a little bit better, where on the right side, if you have antibodies, you get killing and dye exclusion. And then at the bottom, IVIG could bind to these antibodies and prevent them from attacking the cells, and it would be and prevent injury to the lymphocytes. And the first study we did, and this was a placebo-controlled trial, and I think it's one of the first in the NIH-sponsored trials where we had a positive study showing that up in the right, that with using cytotoxicity, that IVIG would reduce the IgG and IgM cytotoxicity versus placebo, and IgG only is shown below. But what we didn't know, and wasn't something that was a primary objective, is that you can see here we got a much better rate of transplantation, and this led to approval, as you indicated earlier, and for IVIG for desensitization here in the U.S. This paper just came out, though, and it's why so old is new again. This is from a group, and Dr. Mully from Australia did a very nice study where he looked at IVIG treatment for people with chronic active antibody rejection. And they got pulse steroids and then 6 months of IVIG therapy, or just the pulse steroids in standard of care. And the study is quite interesting because you can see here that if you look at the biopsy scores on no IVIG, they got worse, they were stable in the IVIG group. And importantly, the GFR was more stable up to 2 years, even after 6 months of therapy. And you can see the declining GFR in the standard of care, which we know they're not going to do well. Protein creatinine ratios, you can see were less in the IVIG group. Ironically, by looking at Luminex, you can see the IVIG had a higher DSAs. Now, maybe they might have had some interference with IVIG in that, but I doubt it would be there at 1 year. But I think below is the most important thing. You can see there really is sort of significant reductions in graft loss and more so death, similar to what we saw with the tocilizumab in our study. So I think this is a very important study, and it just came out. That's in Kidney International, showing that IVIG by itself with steroids can be useful in treating antibody rejection, and that should be looked at more. So maybe it does have applications or it may be working through similar pathways as the FcRn inhibitors. We'll just have to see. But I think there's a lot of other ideas, because what these guys showed, and I don't have this figure, is that they showed, they did a gene analysis of the biopsy, and they found there was a big reduction in those genes of B cells, plasma cells, and immunoglobulin, like I showed you earlier at the beginning of the talk, by the IVIG therapy. And they were using immune modulatory doses at 1 gram per kilogram for these patients. So it's a very interesting paper. We'll finish up here by talking about the plasma cells and innate immunity. And this is some really good work coming from Martin Neeson's group, looking at how antibody rejection works. And I think the thing that I would agree with this, and this is, these are from, protocol biopsies, that there's a real case to be made that the most critical pathways for mediation of antibody rejection and chronic antibody rejection is by Fc gamma 3 receptor, NK cells, and monocytes. And so this would suggest that these are more important targets than maybe B cells or T cell depletion. And one of the things that we've looked at in our place is we do, because we have so many sensitized patients, we developed this assay, an intercellular cytokine assay for looking at NK cells reacting with alloantigen positive cells. And we can see that in the upper right, in the highly sensitized patients, as you can see, there's a release of gamma interferon compared to non-sensitized patients on the bottom. And if you look at, we have about, I think about 500 patients or so, this is in an abstract form, in each group, that looking at BANTH-confirmed antibody rejection, that there is a significant reduction or significantly higher amount in patients who were positive for the NK cell assay. And we think that this correlate, we feel that this may be helpful in patients who have this DSA negative type of microvascular inflammation. We can pick this up earlier before transplant, that we would still want to pay more attention to them. One of the things that we've done is we've used the daratumumab and desensitization. I won't bore you with too much of this, but just a couple of things. We looked at this assay, looking at interferon gamma cells that were positive in this assay. We could really reduce them after daratumumab, and it can last up to several weeks. So NK cell activity can be reduced compared to the T cells. And we've used this as a desensitization protocol now, and we've transplanted like 9 of 11 patients with the daratumumab, who are knocking out the plasma cells. You can see that will help reduce antibody, as we saw earlier. And just even though it's not perfect, if you get at least enough reduction to have to get by with a reasonable cross match, then I think we have the ability to provide transplantation to these patients. I'm going to skip this one. Obviously, one of the most important papers now is this. Excuse me, I'm sorry. Is this paper by Bowman group looking at this another anti-CD38 called felzartamab, where you can show that there was reductions in after treatment for 6 months, reductions in biopsy microvascular inflammation scores, and then the molecular microscopic scores at 24 weeks, although it tended to go back up at 52 weeks. Not much impact on the antibody. That's very interesting. I think this is a really interesting study. And then if you look at the NK cell counts, there is a depletion and a very long effect on this, and keeping them down out to 52 weeks. And also the use of, the donor-derived cell-free DNA very, very helpful here, showing even at 52 weeks there were reductions, and that this correlates with the biopsy findings and could be also useful as a non-invasive biomarker in monitoring how these patients are doing. So this is now underway as a phase 3 study for labeling for treatment of chronic active antibody rejection. So this is good. One of the things we're also working with is another plasma cell-directed therapy. It's a bispecific antibody, anti-BCMA, which is a plasma cell-specific antigen. It's also in B cells. And the other arm is the CD3. So the CD3 T cell comes in, releases cytokines, and kills the plasma cell. This results in plasma cell death and hopefully reduction in antibodies. So this is something that is under study now, and we are encouraged by what we're seeing, but we'll have to have more data. But this is being pursued for desensitization. I think it will be very interesting. I think it'll also, I don't cover today the T cell or the CAR T cell therapies, but this would be a way of getting an antibody-mediated CAR T type effect, bringing a CD3 cell close to the cell of target and killing it. I wanted to show you just in the last few minutes here, and I want to leave some time for this, looking at CTLA-4, which is IG, which is, inhibits the germinal center activities. It's primary. It's not going to inhibit active T cells. And one of the things that we have been interested in is the idea of combining CTLA-4 with anti-IL-6 therapy for immune modulation. And this is a paper that was done, this was with Mo Saeed many years ago with Zhao, with first author, where they looked at a critical role for IL-6 and allograft rejection and tolerance. And what they used here was anti-IL-6 or IL-6 knockout mice. And they showed that with heart transplants, and you can see that by day 7 that there was a lot of Treg infiltrates, whereas the wild type had inflammatory infiltrates. Importantly, the graft survivals you can see there with the wild type were not very good. The IL-6 alone were not good. Wild type CTLA-4 was pretty good, but if you added the IL-6 knockouts to CTLA-4, you got a tolerance picture. It was associated with increased regulatory T cells. And then they had at that time an anti-IL-6 antibody, and they got the same thing. With CTLA-4, you can see it's about 30 days, but with CTLA-4 IG plus anti-IL-6, you get tolerance. And this paper came out last year, which is also a very, very interesting paper, where a similar model in mice, where they use ATG with co-stimulation. You can see that over on the right side, the cardiac allograft survival with ATG and CTLA-4 is best, with ATG alone and CTLA-4 being not as good. And down at the bottom, if you look at what they found in this model is that there were Tregs in the ATG and CTLA-4 peripheral blood, but in the heart, there was inflammatory cells that were IL-6 producing. So if they added anti-IL-6 to this, you get tolerance, again, similar to the other one. And I'll skip this one. I wanted to show you some data from our place, because we've had now 4 people we followed for more than 8 years that have been on this type of protocol with CTLA-4 and anti-IL-6, either TOSI or with CLAZA for 2 patients. And there are 2 patients who had antibody rejection that were converted to belatacept and then maintained on anti-IL-6. You can see here up to 96 months, their EGFR of the 2 patients are very, very stable. And you can see where they were converted at the top of that figure. We did do a geomix here where we looked at the glomerular genes expression pre and post treatment, and you can see that there's a big upregulation of genes after treatment with the two with CTLA-4 and tocilizumab, And this relates to really not so much immune, but to glomerular endothelial and podocyte cell metabolism processes, protein metabolism processes, and assembly. So it looks like the kidney's trying to heal. And again, this is associated with good or with good kidney function over time. These are patients with clazakizumab after CTLA-4 going up, more than 50 months, both having very stable kidney function. They did not have biopsies. So in conclusion, I think that there's several things here we can look at that are going to help us a lot from germinal center, like CTLA-4 IL-6 blockade, potentially, blocking IL-6 for chronic antibody rejection and/or desensitization, drugs like BCMA CD3, daratumumab, belzutifan for treating antibody rejection, also complement inhibitors and the anti-CD38 for blocking the innate immunity, and then imlifidase and anti-FcRn for just getting rid of the antibody. All this is going to be brought together, I think, in a way that will be helpful. So in closing, I think, here was a paper about imlifidase. It's that, we have patients who suffer and stay on the transplant list for many, many years and are unable to get transplanted. And this was an article in Reuters about one of our patients who was first to receive imlifidase. She's now about 8 or 9 years out, normal creatinine, and has a family now. So it's really gratifying to see this at the patient level. And I think, one of the things is that with the problems as we've gone through this whole litany that we've seen years of hard work, struggling through the mud. Now we're really getting somewhere. I think that we'll be able to answer this problem and be able to overcome these antibody barriers for most patients and give them a chance at a transplant. So I think we should always focus on this, try to help the patients and their families. And I think for all the young people out there, and I think all of us, the old ones too, is that we should never underestimate the power of curiosity in medicine and try to do our best to, if you have an idea, maybe it's not such a bad idea, try to investigate it to help patients. So thank you for your attention today, and hope I have some time for questions.
Thank you, Stan, really for this excellent overview of where the evolution is and what is in the toolbox now. So here, very brief, simple question. What's the next combination trial in patients with antibody-mediated rejection? And then follow-up question, who's going to sponsor such trial where you put two competing potential compounds together, where everybody tries to get regulatory approval for the one indication, be the one drug in the market, right? I think that's what we're struggling to convince CLS Behring and Biogen to combine this with with a different drug or with Bella, right? So, but from listening to you, it sounds like we need a combination trial. And how do we design these and pull them off? That's your thoughts would be. Welcome.
Yeah, I know. Thank you so much, Michael. I appreciate that. And I think that's where my thinking is going. And there is one, I couldn't put everything in, but there's been one slide or one study from Europe with imlifidase, where we see this, obviously the big uptick and rebound phenomenon that's really a problem, where they treated the patient with imlifidase and then they used daratumumab post, and they got no rebound, and the patient did great. So that's what we've got to do. I think this is where we have to go to the FDA and say, okay, we need to look at this. And we talked about it when we were in Paris last year with the Hansa people, that we need a study with a companion anti-rebound or anti-plasma cell type therapy where we can prevent that rebound. Now, I think we could do it with IL-6 blockers. I think that worked pretty well for us, and continue them afterwards. But I think it's very doable, and this would really go a long way to solve this problem, because if you clean the deck from antibody, you prevent the rebound from coming back. Over time, we know those, as you saw with the imlifidase studies with general immunosuppression, those antibodies tend to go down. So I talked to Bill O'Connell about this. I said, we need, as a transplant society or American Society of Transplant or whatever, we need to come together with the FDA and say, this is what we need to address this problem. One agent is not going to do it. And I think you're spot on there. So this is where I'm going to try to focus my energies. And I think that even if we could do studies with societies where maybe industry, what I found, they're not interested, they're going to pull a drug away, it doesn't work, and we know it can work, using maybe even like generic tocilizumab, and have our AST or TTS run studies, smaller studies, and prove efficacy. I think this should be accepted.
Thank you so much. Dr. Cornell, would you like to ask your question?
Hi, thanks a lot.
Hello.
We really appreciate, I think, hearing all the history of all the different approaches and then your experience. It's really great of you to share your knowledge on this. And I appreciated that one of your last slides that had the evolving therapeutic approaches to prevention and treatment of antibody-mediated rejection. And my question is, as a pathologist, how can we help tell you, the treating physicians, what kinds of agents to try when? How can we define the rejection on the kidney biopsy so that we know we'd have a good chance? Oh, well, maybe this is the mechanism in this particular kind of this particular rejection. Like we know, or I know, early acute AMR is likely complement mediated because it can be prevented with complement inhibitors. But how do we approach these biopsies in patients later post-transplant, like a year or 2 or 5 years post-transplant, that have some capillaritis and maybe they're C4D positive, usually C4D negative, maybe complement isn't involved, and then you have all these potential mechanisms. But what can we do to further define the findings on the biopsy to help enroll patients in trials and help the treating physicians to know what kind of approaches to take? And I just want to make a comment too. I feel like as pathologists, we've been doing a disservice by calling everything antibody-mediated rejection when much of it probably is not antibody mediated. Maybe there was an antibody, at some point. I appreciate the work from the HLA lab, of course, but maybe later post-transplant, you're not binding an antibody. Maybe there was an antibody in the beginning. Maybe there was never an antibody. And then you still see these kind of changes that look like antibody-mediated rejection, but maybe aren't antibody-mediated.
Yeah. Yeah, I think that, that's really, I think, mirrors the evolution of, BAMF and understanding, and I think we've got better tools now, with molecular analysis and that are companion to the pathological assessments that we have. I think that I would point to the example that, that Ed Wong at our place, we had our patients we treated with TOSI, and we've always felt that they do similar, even if they have microvascular inflammation, they don't have HLA antibodies, they don't have or demonstrable HLA, and they don't have C4D, but they have a similar course to the patients who have HLA and C4D. And I think that was recently shown in a paper that Lupi had in New England, that they do trend very similarly. And then the paper, with the paper we had with the TOSI treatments and the group from Grenoble and from Genoa, that, both groups responded to that. So that's really interesting. I think that IL-6 blockade can really slow this down. And that's a lot of patients, we had 85, they had 64, and a very similar picture there. So hopefully that's helpful information to, that we say, okay, this is an MBI process or DSA negative, C4D negative, maybe IL-6 blockers would be useful, because there, I don't think, you're not, like the studies with the daratumumab or with felzartamab, they're not going to include those patients. They're only going to look at BSA positive patients. So I'm not sure, we got to sort that out somehow. But I think that is what I would be thinking. I think you're right. We see those very early, rapid declining, patients after transplant with antibodies sort of soaring up and TMA features. That's the complement blocker. Be sure we do that first. And I think there's where we need maybe some clinical pathological put our heads together and say, okay, this would be best for this type of lesion, this type of therapy, because we're going to have, we have these therapies now that we can use, but I think it may be not everybody has access to all of them. But I would see also potentially that if we have imlifidase, you have really bad antibody rejection early, that would probably get rid of it very quickly too. But then you don't address the rebound phenomenon. So I don't know if that helps, but I do think that it is something that would be very good, to have that, say this data suggests that, or the data suggests maybe this would respond to IL-6 blockers or to daratumumab or these complement blockers.
Thank you so much. And thank you for staying on a few extra minutes to answer these questions, Dr. Jordan. This was such an excellent talk. I know we're at time, but I just kept thinking while you're presenting, I can't even, when you started this journey in the early 1990s, you probably could have never imagined this talk today, and it's kind of an incredible journey. So congratulations to you.